Now I'd like to introduce our speaker, Dr. Greg Cooper. Greg is a behavioral neurologist practicing at the Norton Neuroscience Institute, where he serves as Chief of Adult Neurology and Director of the Memory Center. He attended the University of Kentucky, where he had received his PhD in 1992 and his MD in 1994. He then completed his residency and fellowship training at the University of Iowa Hospitals and Clinics under the direction of Dr. Antonio Damasio. Greg directed the Memory Disorders Clinic at Iowa before briefly returning to Lexington to join Dr. William Marksberry at the Sanders Brown Center on Aging at the University of Kentucky, and later at the Baptist Neurology Center, where he led the Baptist Health Memory Care Program before joining NNI in 2021. In addition to clinical practice, he has served as PI of numerous clinical trials, primarily in the field of Alzheimer's disease. He is a fellow of both the AAN and the AAPL. Thanks for joining us today, Dr. Cooper.
Thank you very much for having me. And thank you to Norton for helping facilitate this. Okay, I believe I'm sharing my screen now. Picked out 2 or 3 cases to go over that hopefully will be interesting to the group. So I'll dive right in. Okay, so the first case, a 71-year-old woman, initially seen in our clinic back in 2021. And at that time, she presented with a 1-year history of forgetfulness and repetitiveness, repeating herself over and over, asking the same questions repeatedly. Her remote memory, so memory of events that happened in the more distant past, years ago, was relatively preserved. There were not other associated symptoms. There were no impairments in her activities of daily living. Her general neurological examination was entirely normal. On memory testing, we did a mini mental state exam. Her score was 27. And the MoCA, the Montreal Cognitive Assessment, her score was 23. So let me pause there and poll the audience. What would be the next step? We follow her course over time. Would you do an MRI of the brain and screening blood work, neuropsychological testing, or can we just reassure the patient and family that her exam is normal? Give a few minutes for that. All right. We've got some answers in now. Some of you said follow her course over time, which is not unreasonable. And then the 2 leading vote getters were MRI of the brain and screening blood work or neuropsychological testing, which are both reasonable answers in this case. The typical answer would be to do an MRI of the brain and screening blood work as a minimum to look for reversible causes of dementia. I think it's certainly reasonable to consider neuropsychological testing. It would be reasonable if we took the stance that we've already demonstrated on the MoCA that there is some cognitive impairment. And so we don't necessarily have to confirm that with neuropsychological testing, but that answer is certainly not wrong. So we did the usual blood work. That was all normal. We did an MRI of the brain, showed some mild chronic white matter changes, which is often the story. And this is what her brain looked like. And again, you can see, particularly on that higher axial cut, just some little patchy areas of bright signal on a FLAIR image. So the next question then is, what's your diagnosis? Normal aging, mild cognitive impairment, Alzheimer's disease, vascular dementia, or a mixed dementia? Which of those do we think is the correct diagnosis here? We'll give a minute for those answers to come in. And it looks like the majority of the group got this exactly right. So the answer would be mild cognitive impairment in this case. So let's talk about that a little bit. So mild cognitive impairment, simplest definition is an impairment in memory or some other sphere of cognition. So that could be executive function, our ability to plan or organize, manage affairs. It may be in terms of language, it may be in terms of orientation. Most often we'll see memory, but impairment in some sphere of cognition. And then this next part's important: the absence of a significant impairment in our activities of daily living. So we're able to carry out our routine day-to-day activities without too much difficulty. And that's, broadly speaking, the definition. Very common condition. Its estimated prevalence is at least 10 to 20% over the age of 65. It is a condition that puts us at risk for development of dementia. So if I have mild cognitive impairment today, my risk of developing dementia next year is 10 to 12%. But with that said, as many as 14 to 55% have been reported to revert back to normal cognition. And so sometimes it's referred to as an unstable diagnosis. And this sort of illustrates that. If I have mild cognitive impairment in the middle here, yes, that may progress on to dementia, but there is also a chance that it will revert back to normal aging. And there is every chance that it will simply persist as mild cognitive impairment. So it's reasonable to think that it is an at-risk condition, but it's not an inevitability. So another poll then. So we've made a diagnosis of mild cognitive impairment. We've done our all of our evaluation. What's next? No treatment, follow over time, start a cholinesterase inhibitor, start memantine, refer to cognitive rehabilitation. So take a minute to see what folks think. All right. Well, this was a little bit of an ornery question, and I apologize for that, because the truth is we could make a case for each of these. And it's not surprising that there's a pretty good split in answers for this one. So no treatment or follow over time. There are certainly experts in the field that would argue there is not a proven treatment for mild cognitive impairment, and you only treat that condition if someone converts to dementia. So that's not unreasonable. The majority answer would typically be to start a cholinesterase inhibitor. I think most in the field would do that and would point to some limited evidence that these medications do, if carefully selected, help people with mild cognitive impairment. No one bit on memantine, and that's probably reasonable. It's not uncommon to treat people with mild cognitive impairment with memantine, certainly off-label, and that is not necessarily a common thing to do. And then refer to cognitive rehabilitation, either with a speech pathologist or an occupational therapist. A number of people chose that option as well. And that is a perfectly good option. And if we were to be very aggressive, it would not be uncommon to both start a cholinesterase inhibitor and refer to cognitive rehabilitation. So I'm sorry for the question, but all of those are reasonable considerations. All right. Now, we see the patient 2 years later. So we're essentially to current time now. Their forgetfulness, their repetitiveness has worsened, but now they're also having impairments in executive function, that ability to plan, to organize, for instance, managing their medications, managing their finances. Families now assisting with their activities of daily living, including meal preparation. So they now have impairments in multiple domains, and they now have impairments in their activities of daily living. So it would be fair to say that they have now progressed into a dementia. They are currently taking both donepezil and memantine, and their MMSE has declined to 23. And the family's asking about a new medication they've just heard about in Alzheimer's disease, lecanemab. So is the patient a, let's say, potential candidate for lecanemab? Yes or no? All right. So there's a pretty good split on this one as well, but about 2/3 would say yes. and about a third would say no. Are they a candidate for lecanemab? And the answer in this case is at least potentially yes, but we would need a little bit more information before we could say definitively yes, but likely a good candidate. So let's talk about lecanemab. It recently gained full approval earlier in July, just over a month ago now. It is a monoclonal antibody that has high affinity for soluble amyloid beta protofibrils. Now, essentially, think of it as a monoclonal antibody targeting amyloid in the brain. It has been speculated, but not confirmed, that the protofibril stage may be the toxic stage for Alzheimer's disease of amyloid. That's not entirely known. So it's fair to say this is an antibody aimed against amyloid. So why is that important? Well, it comes back to really the major idea in Alzheimer's disease, the amyloid hypothesis. And it states this fairly simply. It's the deposition of amyloid or beta amyloid or A beta in the brain that is the key trigger to a long, complex cascade that ultimately leads to Alzheimer's disease. And it looks a little bit like this. So at the very top, we have the deposition of amyloid. That leads to synaptic dysfunction. So dysfunction of those synapses, the connections between brain cells. That leads to tau-mediated injury. That's where you get neurofibrillary tangles. So if we think back pathologically, you have amyloid plaques and neurofibrillary tangles. The tangles are the tau part. And then you get atrophy. The brain shrinks more than would be normal for age. And it's at the very end of this that you see the cognitive decline. Now, if you look at it, these are from looking at biomarkers in the brain. So it's a way of measuring when these different steps happen. And the first curve to go up is beta amyloid. And then it's this tau-mediated injury, so the tangles, the brain structure, that's atrophy, and then memory, and then clinical function at the very end. So that is taken as support, not proof necessarily, but support for the amyloid hypothesis and for the idea that amyloid may be the root problem, the initial step in the development of Alzheimer's disease. So we developed a medication, lecanemab. It's a monoclonal antibody targeting amyloid, and the goal is for it to remove amyloid from the brain. So this is proving that it does that. If you look at patients who are part of the pivotal trial that received this medication, and now we're doing PET scans, so we're measuring amyloid in the brain. That top blue bar is placebo, so the patient not only continues to have amyloid, but it actually goes up slightly over time. If they receive the medication, you can see that amyloid level rapidly drops over 12 to 18 months. And many of the patients in this trial were essentially amyloid negative at the end of the trial. So we can be pretty confident that it does what it's supposed to do. It removes amyloid. Does it actually help? So this is another graph from the same study. It's looking at something called the CDR. It's a clinical dementia rating scale. And think of it simply as a measure of global function in Alzheimer's disease. And what you see, the blue bar is placebo, that's the expected decline, and the gold bar is the decline, the course of patients on lecanemab. And it slows that progression. That's essentially what you're saying. And you can be hopeful, but this isn't really established. Perhaps that gap between the two lines gets wider over time, but that's a little bit more speculative. So we do see there is clearly some clinical benefit. It doesn't stop, it doesn't arrest the disease, but there is clinical benefit. Now, if you look at it, I just pulled out some of the main outcome measures. What we generally tell people is it slows progression by about 30%. Now, that varies between measures. The main outcome measure, by the way, was 27%. The lowest outcome measure score was a 23% difference. The highest was 36%. All of these highly statistically significant. So we have pretty good evidence that it removes amyloid, and now we have pretty good evidence that it at least slows the progression and approximately 30%. Now, what about the eligibility criteria? And this is based on an expert panel that gave recommended use criteria. Eligibility would be mild cognitive impairment that we believe is due to Alzheimer's disease and mild Alzheimer's disease. And they recommended a cutoff on the mini mental state exam of 22. Some people might push that to 20. The bottom line is we want people in the very mild range of disease, age 50 to 90. That's simply because that's what the trial reflected. And then the presence of pathological amyloid. We have to show that there's amyloid. That ties back to the MCI due to Alzheimer's disease. You can have mild cognitive impairment, but not be due to Alzheimer's disease. We have to prove that there's amyloid present, and that's what would convince us the MCI is due to Alzheimer's disease. So the way we do that as of today is with a spinal fluid exam. And this is, we send it out to the Mayo Clinic laboratories, and this is what it looks like. The most important measure is this ratio. They're looking at phospho-tau and A-beta 42, and that should be high. Perhaps counterintuitively, the A-beta, the beta amyloid level, is low. The thought is, as you form plaques, you're pulling all of the amyloid out of solution in a sense. You're forming plaques. And so when you look at the spinal fluid, that beta amyloid level will actually be low, and your tau levels, total tau and phospho-tau, will be high. So this is what the report looks like. And in this particular patient, it confirmed the presence of amyloid as we expected. Perhaps as early as later this month, CMS will approve PET scans. So that'll be another way to look for amyloid. We can order an amyloid PET scan and look for pathological amyloid in the brain, but we're not there yet. Those are the main criteria. What are the exclusionary criteria? Well, inability to have an MRI, and I'll explain that later, but we have to do a baseline MRI and repeated MRIs over time. And then the biggest exclusion criteria are criteria that might put us at a higher risk for bleeding. So if you saw multiple microhemorrhages on an MRI, it's not uncommon to see 1, 2, 3. If you have more than 4, that's an indication that you might have cerebral amyloid angiopathy and are at high risk for bleeding as a complication of this treatment. If there's a single macrohemorrhage, large hemorrhage, or superficial siderosis, those are things we'll see on the MRI. That would tell us not a good candidate. More than a couple lacunes, if there's a stroke involving a major vascular territory, or if there's severe subcortical hyperintensities, those criteria may change over time, but we're taking a very conservative stance right now on who should get this medicine. Anticoagulant use. In the trial of lecanemab, people were allowed to be on anticoagulants. And if you just look at the trial by itself, there did not seem to be an increased risk in those folks. But because this class of drugs is associated with a risk of bleeding, out of an abundance of caution, we're advising people on anticoagulants not take this medication right now. Again, that may change over time. I won't go over all of the rest of these. So how is it administered? It's a complicated medicine. It's an intravenous medication. It's given every 2 weeks, 10 mg per kg. The infusion itself takes about an hour. For the first infusion, we want to watch people for about 3 hours, after the second one for a couple hours, and after that, maybe only 30 minutes. There is about a 1 in 4 risk of an infusion reaction. These are usually pretty mild, maybe feeling a little achy, possibly a little feverish, and something that can easily be treated with medicines like Tylenol or diphenhydramine. And if we see that, we can pre-medicate folks subsequently. So there is a significant risk of infusion reactions, but those are pretty mild, and frankly, we're not too worried about that. But this is taking me into what we do worry about. So we have to do MRI monitoring. We do an MRI within 12 months of starting to make sure there are no exclusionary features like amyloid angiopathy or prior hemorrhage. But then we need to do it before the 5th, 7th, and 14th infusions. And the reason is because of something called ARIA. It stands for amyloid-related imaging abnormality. And if you really just boil this down, it means swelling or bleeding in the brain. Now, as many as about 21% of people getting lecanemab are expected to have ARIA. But the great majority of those people have no symptoms at all. It's only about 3% that have any symptoms. So again, from this expert panel, what they said is most cases are asymptomatic. Few cases are serious, and few really means probably around 0.7%, less than 1%. Very rarely, they could be fatal. In the original study, there were actually fewer deaths in people on medicine than on placebo. But since that study is reported, there are a couple people that did have fatal bleeding, one who was on an anticoagulant, one who got TPA for stroke, but we want to keep a careful eye on that. We do typically now recommend genetic testing, ApoE testing, and the reason is this: it can give us a better idea what their actual risk of symptomatic ARIA is. So if someone has 2 copies of the E4 allele, their risk is higher, around 9% of having symptoms. If they are non-carriers or even heterozygotes, their risk of having symptoms due to ARIA now falls below 2%. So it's not mandatory that they have this testing, but we recommend it so we can give a more accurate view of the risk of side effects. So this patient did end up being a good candidate. They started on lecanemab, and now they had an MRI before their 7th infusion. That was scheduled, a safety one. And the radiologist is telling us that they have mild radiologic ARIA, so some mild swelling or bleeding. The patient is having no symptoms at all. And here's what that might look like. This is not from the actual patient, but you can see it best in panel B up here where the arrows are. There's a little bit increased edema on this flare image. So that's ARIA E for edema. And then in this lower panel, if you look at D, those little black dots in the circle, those are microhemorrhages. Now, in reality, they're microscopic, but on a gradient echo image or susceptibility weighted image on the MRI, they bloom. So they're larger than they are in real life, and you'll see that little black dot. So both of those are indications of ARIA. One is edema, one is hemorrhage. And that's the sort of thing we might see on an MRI. So again, the patient is doing well. They're not having any symptoms, but the radiologist is showing us these findings. So what do we do next? Do we stop lecanemab? Do we continue lecanemab and just monitor carefully for any symptoms? Do we continue the lecanemab and repeat the MRIs each month? So take a second to answer that. And in this case, there is a single right answer. All right, so now understandably, this is a very new medication, so the answers were across the board, but I think it illustrates the case. In this particular case, we would continue the lecanemab, but now we would repeat MRIs monthly until the radiologic signs either disappear or they stabilize. So in the case of edema, we're monitoring to watch for the edema to disappear. In the case of the microhemorrhage, we're monitoring to make sure that that doesn't continue. Now, if the patient had had symptoms or if the radiologist told us that they were seeing really severe changes on the MRI, that might have been a reason to stop the lecanemab. But in this case, if they're asymptomatic, we can continue. And in the great majority of the cases, those signs are going to go away on the MRI, and the patient will never develop any symptoms. Okay, so enough about lecanemab. Let's shift gears now. We have a 78-year-old woman, a history of mild to moderate Alzheimer's disease. She has impairments in memory and orientation and executive function. And the family is reporting to us that they're noticing increasing tearfulness and increasing statements of hopelessness. So we suspect depression. So what would our potential strategies be at this point? Well, we can investigate and address any psychosocial or environmental issues. So it is possible that this is a situational depression. Maybe they lost a close family member. Maybe there has been a change in the environment that has been threatening to them and led to this. So we would want to explore that. Look for opportunities to increase social engagement. Maybe the part of the issue is isolation and loneliness. And frankly, even if not, we know that increasing that social engagement is frankly good for brain health in general and can help with depression. But it's also reasonable to look at medications. And generally, in this case, we would look at an SSRI, something like escitalopram, fluoxetine, sertraline. The nice thing about them is they all generally have adverse effect or side effect rates similar to placebo. It is often written to avoid paroxetine due to anticholinergic potential. I will say in actual practice, I don't often see that a problem, but as a general rule, some of these others are probably better tolerated. It might be best to avoid or at least use the SNRIs like duloxetine and venlafaxine with some caution. There is at least report of increased risk of side effects, including falls. Again, not something I commonly see, but if someone is on an SNRI, it should alert us, and it's fair for us to be a little bit more vigilant. So now, same patient a little bit later, their depression is better, but now they're starting to have visual hallucinations. They're starting to see people in their home who aren't actually there. So next poll question, what would we do in that case with new onset hallucinations? Would we avoid treatment if we can? Would we try haloperidol, try quetiapine, maybe try pimavanserin, or maybe try brexpiprazole? What do you think? And there are multiple answers. I think one is better than the others. So actually the winner in this case was to try quetiapine, which is a pretty reasonable answer, I would argue. The second place vote getter was avoid treatment if possible. And I would argue that that may even be a better answer. If someone is having hallucinations, but they're not threatening, they're not disruptive, then we may not necessarily have to treat them. We keep an eye on them, we monitor them, but it's not infrequent that I'll see someone who has hallucinations, but it really doesn't have any impact on either the patient or the caregiver. So again, in that case, if we can be conservative and hold a medication, that's a good idea. I'm happy no one wanted to try haloperidol. Certainly we would stay away from the older typical antipsychotics if possible. I think if we were going to start a medicine, I would absolutely agree that quetiapine is a very good choice. Pimavanserin is sometimes used, but that's really thought of more for Parkinson's disease dementia. Brexpiprazole has recently gotten a FDA indication, so it wouldn't have been wrong to use this. But I think quetiapine was a very good answer if we need to start a medication. I guess I should have switched to this slide already. So the first step in evaluating psychotic symptoms, and psychotic symptoms would refer to hallucinations, so false perceptions, but also delusions, false beliefs, believing that someone is stealing from you, believing that a spouse is cheating on you. So those would all fall under psychotic symptoms. So first determine if treatment is necessary. If we can reassure, if we can redirect, if we can do some behavioral intervention, then that's probably preferable, frankly, to starting a medication. Interestingly enough, there is some evidence that cholinergic therapy, the cholinesterase inhibitors, may help. So if a person was not already taking a cholinesterase inhibitor, starting one, particularly if the symptoms are relatively mild, may actually treat and improve those symptoms. Memantine, at least there is some anecdotal evidence for that as well. But then if the symptoms are quite severe, we would typically go to an atypical neuroleptic like quetiapine, like risperidone. Olanzapine, probably farther down the list, but not unreasonable to consider. But we do have to think about the black box warning that's associated with these medications. And what that really states is this, that if we give someone who is geriatric with a dementia, atypical antipsychotic, they have an increased risk of stroke or mortality. And at least in the original reports, they would give an odds ratio of around 1.5 to 1.7. If you really want to dig down to the numbers, the risk is about 2.3% on placebo versus 3.5% on medication. And it's generally thought that that mortality is present early on in therapy. As we progress longer on treatment, that risk may go closer to that of placebo. There have been subsequent reports that have suggested that while we think of this as a class effect, some medications may be at lower risk than others. And in fact, at least one report I'm familiar with has suggested that there is no increased risk with Seroquel. But nevertheless, the black box warning from the FDA applies to all of these medications. All right. So go on to this is my last case. So case 3. And it's maybe a little bit of a left turn, but I thought it'd be interesting to the audience and something I see every week. So 55-year-old man comes into clinic with a family history of Alzheimer's disease. A mother had symptom onset in her 70s, and then a maternal uncle with symptom onset in his 70s. Now, he notes occasional memory lapses, and it's not clear if that was something he just said to get his way into the clinic or not, but he endorsed that. What he described, though, was forgetting why he went into a room or missing a turn when driving. And so it's worth pausing on that just a little bit. What he is describing are really problems with, we might call it complex attention or working memory. He just did not keep into his head for those 30 seconds why he went into the room. Or while he was driving, he lost attention or lost focus, was thinking about something else, and that led him to miss the turn. And then he realized it and got back on track. Those are very different than the types of memory lapses that someone will see with Alzheimer's disease, for example. In that case, it's better thought of as a problem of recent memory. They forget a conversation they had a few minutes ago, not 30 seconds, but a few minutes ago, or earlier in the day, or yesterday. It's not that very immediate memory or very immediate issue with attention. So it's fair to say this is someone that's noticing lapses, but they're not the kind of lapses that would really make us suspicious that he's developing mild cognitive impairment or Alzheimer's disease. And he doesn't have a history of early onset dementia. He has a history of more typical late onset dementia. So we'd be surprised if he had any problem right now. We do a brief mental status test just to be sure. And he had a Montreal Cognitive Assessment or MoCA score of 29. So this is someone that's cognitively intact. You might refer to them as worried well. So no risk of dementia at this time, but because he has a first-degree relative with Alzheimer's disease, his risk is now double what it would be if he didn't have a family history. The maternal uncle actually probably doesn't add anything to his risk. It's the mother. It's a first-degree relative that doubles his risk. So then the question is, can that risk be reduced? Well, Lancet Commission, they've had 2 different reports now. Their last report in 2020 reported that 40% of dementia worldwide is preventable. So that's a pretty large number. And they break down the 12 items that they think are preventable risk factors. And some of those are things that we can do individually. Some of those are really at a population level. We may not be able to interact or to impact individually, but let's go through those. So minimize diabetes, treat hypertension, prevent head injury, stop smoking. We have some ability to control all of those. Reduce air pollution. We can't do that individually, but societally, if we could significantly reduce risk of dementia. And then reduce midlife obesity. Doing all of those things reduces, we think, the neuropathological damage, amyloid or neurofibrillary tangles, vascular disease, inflammatory disease. All of those things reduce risk in that way. They reduce it at the level of brain pathology. Then some other items: maintain frequent exercise, watch, reduce, treat depression, avoid excessive alcohol. So that probably helps us both at the level of brain pathology, but then it also goes down to this lower box, increasing and maintaining cognitive reserve. We build up that cognitive reserve, that builds up our resilience to the pathology that may be coming from the top box. So that makes us more resistant to the changes of dementia. And then down below, treating hearing impairment, maintaining frequent social contact, attaining high level of education. Those act by cognitive reserve, and then that together prevents dementia. So let's think about this a little bit more individually, and I'll include some additional risk factors beyond what the Lancet Commission identified. So education, early life education is thought to reduce our risk, and that may account for about 7% of our risk. But it's not just early life. We can continue to build resilience through learning new skills by being mentally engaged by education. Some midlife risk factors: excessive alcohol intake. And they gave a fairly high number here. If having more than 9 glasses of beer, 9 glasses of wine per week starts putting us at risk, a better number to think about is maybe 1 to 2 drinks for men, a half to 1 drink for women, or probably even better, 1 drink per day for men, half a drink for women is a pretty safe number for us. High blood pressure, obesity, hearing loss, traumatic brain injury. I will admit, I and many of us probably didn't pay attention to hearing loss as well as we should have. And that's something we should look into. If our patients have hearing loss, treating that may truly lower their risk of dementia later on. And then later in life, the most important risk factors: smoking, social isolation, inactivity, and air pollution. Going beyond this, or building on this, neuropsychiatric disease, anxiety and depression looks like a significant risk factor. There's a risk of reverse causality. What that means is I may develop depression shortly followed by dementia. Did the depression cause the dementia, or was that in fact one of the early symptoms of dementia, and my dementia simply wasn't recognized? So it's a little bit tricky to sort that out in the research, but I think it's fair to say from a pragmatic standpoint, if we see evidence for anxiety or depression, certainly we want to treat that. Heart disease, atrial fibrillation, heart failure, hypertension, sensory impairment of any type, vision, hearing, those may be real risk factors for dementia. Other risk factors: cancer may put us at a higher risk. Polypharmacy, now that may also just be a risk factor of multiple other medical comorbidities that are a risk factor in and of themselves. Diabetes, respiratory disease, and traumatic brain injury. Medications, and this is debated often, but certainly we want to try to limit anticholinergic medicines, benzos, the Z drugs like zolpidem or Zolpidem. The evidence on all of these is mixed, and there is some thought: is it causative, or if you're on these drugs, is it simply driving the symptoms of the underlying disease? It's exposing the disease that's already there. But at any rate, it's reasonable to really try to limit those drugs. Then an important one that a lot of us speculate will be in the next Lancet Commission report is sleep. We should strive to get 7 to 8 hours of sleep a night, and getting less than that may really put us at risk for developing a dementia or an untreated sleep disorder. If I have moderate to severe sleep apnea and am not treating it, there is some real concern that that puts me at a higher risk for the development of dementia, whether that be Alzheimer's disease, vascular dementia, or other. So what can we do? So what should be our advice for this young man that came in with a family history? And at least at this point in time, it's relatively broad, relatively simple, I think. First of all, manage those vascular risk factors. I always tell people, stay in close contact with your primary care provider and pay attention to your blood pressure, pay attention to your blood sugars, etc. And then I tell people to remain active in these three broad areas: mental, physical, and social. Doing things that challenge us mentally. It doesn't matter if it's what the details are, if it's puzzles or crosswords or learning a language, an instrument, reading, doing anything that engages us mentally, exercises our brain just like any other muscle. And then getting good regular physical exercise. And that can be as simple as walking 20 or 30 minutes 5 days a week, but getting some regular physical exercise. For people who are really motivated, there is some evidence to suggest 2/3 of your activity should be aerobic and 1/3 should be toning, more muscle building. But I'm happy if people are just physically active and getting regular exercise. And then social, maintaining those social contacts. That probably acts by helping build our resilience to dementia. But at any rate, maintaining a good social network and getting that social activity. And then I do recommend people get adequate sleep, both in terms of quantity, but also in terms of quality. And if I have suspicion they may have a sleep disorder, I will refer them for a sleep evaluation. And then the last thing is diet. And there is increasing evidence of the importance of our diet. And the two that are most often recommended are the Mediterranean diet and the MIND diet, keeping in mind that the M in MIND stands for Mediterranean. It's a combination of the Mediterranean and DASH, which is a diet that was developed for hypertension. And both of these are very, very similar diets, and both have pretty good evidence to support them. It keeps going back and forth, which has the best evidence. One study of the MIND diet showed that if you followed it very religiously, very regularly, you could reduce your risk of dementia by about 53%. If you followed it just pretty well, maybe not perfectly, but did a pretty good job, you still reduce your risk of dementia by about 1/3. So those are pretty big numbers. So if we look at the MIND diet, and I won't pretend I understand or have all of this memorized, but there are some pretty easy guidelines, and these are easily looked up. Leafy green vegetables, 6 servings or more a week. So as a round number, plan on getting 1 a day. Other vegetables, try to get 1 a day. Nuts, 5 servings a week. Berries, at least a couple servings a week. Incidentally, berries are thought to be important in helping clear out or limit the very pathology we see in Alzheimer's disease. Beans, whole grains, fish, poultry, olive oil, really cooking in olive oil or at least a vegetable oil, but olive oil might be the preferred one. Much better way to go than butter. And then there are some things to limit. And fortunately, it doesn't say we have to eliminate these, but really limit red meat to less than 4 servings a week, limit butter, margarine, limit cheese, limit pastries, sweets, and fried or fast food, and really all of the things that you would expect. And this is just a slide. You can easily find different images on the net. This is from Wisconsin's Alzheimer's Disease Research Center. It really does a pretty nice job of outlining the things that we should avoid. And those are all of my slides. Not sure if I went under or over, but I'll stop slide sharing there.
Yeah, I think you're perfect actually on your time, Greg. I appreciate it. I know I learned a fair amount today, so I hope that everybody else did. So I don't see that we have any questions from our participants yet, but I did have a couple that came up. So in your first case, you talked about that doing the MOCA was reasonable versus doing the neuropsych because you that not doing the neuropsych because you had done the MOCA, you knew that there was some degree of cognitive difficulty there. So I know how in-depth the neuropsychs are. I've read the 32-page reports and all of it they entail. So they give very specific, it's this type of decline in this area of functioning, et cetera. I don't expect that detail, but I have forgotten what information do we get from the MOCA? Because I know it's different from any mental status.
Well,
do you get any idea of what type of dysfunction you're dealing with?
You do, and I'll apologize in advance if this is a little bit of a long-winded answer. Really, I look at these bedside tests primarily to show me that there is impairment, first of all. So I want some confirmation that it's likely impaired or not impaired. Now, beyond that, I would tell you the diagnosis is made primarily by the history at that point. So if somebody gives me a history of, pretty typical, an amnestic pattern, they're repeating themselves, they're repeating their stories over and over again, they're misplacing things around the house. Pretty typical story of mild cognitive impairment or Alzheimer's disease. That's what I'm interested in. And I'll ask, do they have problems in language? Are you seeing problems in visual spatial orientation, getting lost, things like that? But it really is the history that is most important to me at that point. Now, if we look at the two most commonly used tools in the office are the mini mental state exam and the MOCA. The mini mental state exam gets the criticism that it is so heavily based on memory. So the first several points are on orientation. What day is it? Where are you? Well, they say it's orientation, but that's actually a test of memory. So right off the bat, 10 out of your 30 points are all short-term memory. And then do you remember 3 items after a delay? Well, that's another 3 points. So very nearly half the test is just memory. And the criticism is you're not testing other things like executive function, like languages effectively. So the MOCA has 2 advantages. The MOCA is a more sensitive measure. So someone may have mild cognitive impairment or mild Alzheimer's disease and still score normally on the mini mental state exam. They should not score normally on the Montreal Cognitive Assessment. So it's more sensitive for early disease. And then it also has the advantage that it's looking more into executive function. It's doing better testing of visual spatial function. It's doing better testing of language. So you do get a more complete view there, which I think is helpful. For me, the primary advantage is the increased sensitivity. Now, let me pivot a little bit to the neuropsychological testing. You're right. You get an enormous report out, and you get a lot of detail. But I often find it's giving me detail that I don't need. And it's often leading me to an answer that may or may not be true. So when a good neuropsychologist is partnered with for the right patient, for the right reason, the benefit is absolutely enormous. So somebody where I just can't decide, do they really have some degree of impairment or not? They can really help me with this. Or am I worried that they have some unusual form of dementia, like a primary progressive aphasia, and I need a better language assessment? They are enormously valuable in that case. But if I just coldly send them someone who may or may not be impaired, you'll often get a report back saying, well, we see this frontal subcortical circuit dysfunction. So maybe they have frontal temporal dementia. Well, they probably don't. They may be depressed. They may have polypharmacy. They may have multiple other medical comorbidities. And you'll get this non-specific report back almost as if I, as a neurologist, send everybody off for a SED rate, and I get a non-specifically elevated SED rate, but then I don't know what to do with that. So that's really, I think, the reason I'm a little more selective over pulling the neuropsychologist in. They are an extremely valuable partner if you're partnering with them with a good specific question. If it's more of a broad shotgun approach, I just don't often get that much out of it. That's my own bias.
Thank you. So in discussing the risk factor reduction for dementia towards the end, and we talk about treating hypertension and then exercising as well. So treating the hypertension, that is your chronic baseline hypertension, getting that to a controlled level, not considering that during exercise, we're obviously going to become hypertensive if we're involved in aerobic exercise. So that is the benefit of the exercise is worth that 30 minutes to an hour a day of increased blood pressure.
It is. And I even throw one other caveat in there. So if it's all about prevention, so hopefully I don't have cognitive impairment and I'm trying to avoid it, then I really want that blood pressure well controlled, less than 120. If I have some degree of vascular cognitive impairment, then there is a significant group out there that would argue, allow that blood pressure to be a little bit higher, maybe between 120 and 130. So slightly higher. You don't want it to be 150, but if someone has evidence for vascular disease and evidence for vascular cognitive impairment or dementia, then it may be okay to liberalize it slightly with the theory that maybe you need a higher blood pressure to perfuse. Does that make sense?
Yes. So would that include some of the hypertensive issues that may be like with lacunar infarcts, et cetera, where it's a different type of vascular dementia? It's not necessarily the microvascular.
The real answer is we don't know all of those answers yet.
Okay.
I think it would be fair to say if someone has multiple lacunes, then you have good reason to think they already have some degree of small vessel disease. And so it would be reasonable to suspect they may have a little bit more trouble perfusing. And so in that case, it's okay to be slightly more liberal, not wildly more liberal, but I think that group, it's fair to allow that number to drift slightly higher.
Okay. And then I think I don't see any other questions. My last question that I came up with. So I know you talked about sort of the inheritance sort of issue with first degree relatives and doubling your risk. So, and then your other example is like a third, fourth, or fifth degree relative that was, maybe by marriage. So,
Yeah.
I mean, completely not an increased risk at all. What about second degree relatives? Because a lot of people that are listening to this are going to be at the age where they have grandparents that may have an issue. So a direct second degree relative.
The best evidence that I'm aware of would say no, that for that increased risk, it has to be a first degree relative. Okay. It doesn't mean I might not use that to really push people to take good care of themselves, to do those preventative things. But really, if it's grandparents, if it's cousins, that probably is not having a big impact on our personal risk.
Okay. And I don't see any other questions. I appreciate you coming on today. And I think that I do think it was full of a lot of great information. And like I said, I believe that that people got a lot out of this today. So I certainly appreciate it.